which encourages the informed and active participation of citizens in government. We influence public policy through education and advocacy, and we focus significant effort on registering new voters. The League of Women Voters is not limited to women. Men are most welcome to join us in making democracy work. On behalf of all the members of the Rochester League, I'd like to welcome you to our April Forum, the 5th anniversary of the Affordable Care Act, Challenges of Implementation. We're proud to present this panel discussion, and we're especially pleased to be able to offer a question and answer segment following the presentations. We request, of course, that all our guests respect our panel, our hosts, and the League's own commitment to civil and respectful discourse. And now, it's my pleasure to introduce our distinguished moderator this evening, Sarah Liebschutz. Sarah is a Distinguished Service Professor Emerita of SUNY College at Brockport, where she was a member of the Political Science and Public Administration faculties for 27 years. Her research, publications, and teaching were and continue to be focused on American public policy, including health policy. Her most recent book, Communities and Healthcare, the Rochester, New York Experiment, was published in 2011 and reissued in paperback in 2013. Sarah has been a member of the Rochester League of Women Voters for more than 50 years. She's a graduate of Mount Holyoke College with a PhD in political science from the University of Rochester. Welcome, Sarah.
Thank you very much, Mary, for all you do as co-president of the League. Mary and I have known each other a long time. She was a former student of mine. But I take no credit for her smarts or her organizational capacities.
Thank you.
Shortly after the Affordable Care Act was signed into law 5 years ago, in March 2010 by President Obama.
It's a little louder. Can we turn the volume up or something? Yeah, that's good.
Even louder than this?
No, that's fine.
This is good?
That's better, yeah.
Okay. All right. What I was saying was that 5 years ago, shortly after President Obama signed the Affordable Care Act into law, 2 women were overheard in conversation at a reception. They knew that each was the mother of a physician, and they commiserated as they projected that the doctor's son and the doctor's daughter were soon going to be in the poorhouse because of Obamacare. What a mess, one said, and the other one agreed. That was the end of that conversation. Now, we don't know, of course, if these young doctors went into the poorhouse. We sort of doubt it, but it's a good way to begin our conversation. And to begin it by saying that on this, the 5th anniversary of the Affordable Care Act, its formal title is the Patient Protection and Affordable Care Act, but we just call it the Affordable Care Act, is either the worst or the best piece of legislation ever enacted by the Congress. People are generally not neutral. At the same time, most Americans are quite confused. They're not clear what the act says, what it costs, and what difference it makes. Our purpose today is to try to lift that fog of ignorance, probably not entirely, but hopefully a little bit, as we update some highlights of the first 5 years and also project to the future. First, a few words about the position of the League of Women Voters on the Affordable Care Act. The New York State League and the United States League supported the Affordable Care Act during consideration by the Congress and continue to support it as a step forward for health care reform. At the same time, the New York State League of Women Voters is advocating strongly for a single-payer concept, which stresses equitable access and cost containment. The League is, in fact, actively lobbying the state legislature to pass the New York Universal Health Care Act, single-payer legislation sponsored by the Assembly Health Committee Chair, Richard Godfrey. Next. Now back to our challenge to lift the fog of ignorance and confusion about the Affordable Care Act. This is how we're going to go about it, as you can see on the screen. I will start off with a brief overview of the history and the current status of the Act. Then our three distinguished panelists will discuss challenges whose resolutions may well determine the future shape of health care for Americans. Brief history. If we look back at the Democratic presidential primaries in 2008, we quickly become aware of the fact that what many now call Obamacare, I don't call it that, because I think it's pejorative. I call it the Affordable Care Act, but a lot of people call it Obamacare. That was not the exclusive priority of Barack Obama. In fact, all three major contenders for the Democratic nomination, Obama, Hillary Clinton, and John Edwards, emphasized health care in the debates and on the stump. And that was for one very simple reason. Polls at the time showed that health care was a very high concern to American voters, all voters, but particularly Democrats and particularly Democratic primary voters. By the time the primaries and the general election were over, Barack Obama, the winner, was saying publicly that he wanted to do, quote, health care in his first term, end quote. And that is exactly what he did. 1 month after his inauguration in January 2009, when he highlighted his 3 goals for health care reform. Next. Access, cost, quality. He wanted to improve, as a goal, the availability of health care. And this involved and involves making available health insurance for more Americans. 50 million Americans in 2009 were uninsured, health care uninsured. And his second goal was to contain the growth of the costs of health care. Bending the cost curve means to turn that escalating slope of healthcare costs in a flat and in a downward direction. And one way of doing that is to reduce waste. And finally, he was concerned about quality of care, improving quality of care. Next slide gives you just a very brief summary of the path through the Congress of the Affordable Care Act. It's important to realize that it was not smooth and it was not bipartisan. Rather, it reflected between the Senate passage by a 60-40 majority and the March passage by the House of the legislation, something that happened around a death and the election of a successor. And of course, I'm referring to the death of Ted Kennedy and the election, he was a Democrat, and the election of Scott Brown, Republican, as his successor. That made impossible a filibuster-free Senate. And so what the Senate did, anticipating that this might happen, was to skirt the possibility of a filibuster, which could hold up the bill forever in the Senate, by passing majority rule instead of a 2/3 rule to pass amendments in what would be normally, in the course of legislative process, a reconciliation bill. Very brief explanation of that. And I also said, in addition to the fact this wasn't a smooth process, it was not bipartisan. Even though President Obama made efforts to create a bipartisan consensus, the legislation was passed in each house by Democratic votes only. Not a single Republican representative or a single senator, Republican, voted for it. Now, the Affordable Care Act is complicated and it's long, more than 2,700 pages in length. Somebody asked me tonight, have you read every page? And I said, no, of course not. I've only read sections that are pertinent to my interest. But what makes it so interesting and so unusual is not that it's so long, because many tax bills are very, very long, thousands of pages. But the fact that although adopted in 2010, the full rollout of all the provisions extends to 2018. We're not even fully implementing this act yet. With 2014, the banner year for implementation of its most partisan and publicly contentious issues, the individual mandate and two mechanisms that I'll shortly explain to implement it. Why the delay in implementing these central features of the Affordable Care Act? It was a gamble. It was a gamble taken by backers of the law who thought that the well-accepted provisions in the first couple of years would soften opposition to the individual mandate and other provisions. But that gamble really didn't work. In fact, the opposition didn't soften, and in 2012, midterm election campaigns were marked by loud opposition to the act, energized in part by Tea Party supporters, and resulted in a Republican majority in the House of Representatives. In 2014, the individual mandate, next slide please, for health insurance, mainly affected by persons not covered by employers, people between the ages of 18 and 64 approximately, and with penalties levied on those who don't comply. With that, let's have the next slide, please. And in addition, the two mechanisms that would implement the Affordable Care Act. The insurance exchanges, new state-based marketplaces to offer quote-unquote affordable plans, and expansion of Medicaid eligibility to legal residents up to 138% of the federal poverty level. As you will shortly learn in much greater detail, the constitutionality of the individual mandate was upheld, but not that of the Medicaid expansion in a 2010 decision by the Supreme Court. I would just point to the expansion as a threat to losing all Medicaid funds. That linkage is very important to appreciate. Now this next cartoon shows Chief Justice John Roberts, who wrote the majority opinion. It was a 5-4 opinion, with the bill, the 2,700 pages, saying to Nancy Pelosi, I had to rewrite your paper, Nancy. I gave it a grade of D-, but it passed. And Nancy Pelosi is saying, cool, what was in it? How did you rewrite it? It was a confusing decision and in many ways a very unexpected decision. Now the court is expected to hand down a decision in June regarding the constitutionality of a provision regarding the state and federal health insurance exchanges. But without stealing any more thunder, particularly from my third panelist, I would like you to look at maps that were handed out to you that show decisions by the states. Next slide, please. Although this slide, this is for me a conundrum of technology. On my screen and my computer, this is what shows. But yours is printed out in orange. I don't know. But this map and the other one, just hold on that.
You're the one.
Were prepared by the Kaiser Family Foundation. And they show, this one in particular, shows the decisions by the states regarding Medicaid expansion. Just a word on that. To expand Medicaid means that you have to liberalize the eligibility requirements, making more people eligible. And the District of Columbia, since all these things don't add up, as you can see on your own maps, on the right side here, they add up to 51. District of Columbia is considered a 51st state. So, what do we see here? We see here that 29 states, mainly east, in the east, southwest, and the west, including the District of Columbia, have adopted, and 6 more are considering adopting the Medicaid expansion. And my husband, who was a lawyer, used to say of his clients, doesn't matter what they say they're talking about money. And in the case of the states, some of which surprisingly have gone for the Medicaid expansion, it has to do with the incentive of federal funds covering 100% of the cost of expanding for a few years and then 90% thereafter. However, I would make note of the fact that 16 states have not adopted the Medicaid expansion. So that's not universal. It's not 50 states. It's 34 states in the District of Columbia. The next map is an overlay of the states that have expanded Medicaid and those that have decided on the state exchanges. And what this map shows, and you can read it in the legend below, is that only 17 states, including the District of Columbia, have state exchanges. 34 states have not, and instead rely on the federal exchange, which is called healthcare.gov. This is almost a mirror image of what we saw for Medicaid expansion. About the same number of states have state exchanges, only 17. Which is about the number having expanded Medicaid. And so it's an interesting comparison here. And we're waiting with bated breath for the decision of the Supreme Court in June, because that may well determine what those 34 states who don't have state exchanges will do. Finally, I want to say a few words about public opinion in the Affordable Care Act. The Act has never had overwhelming support, public support. Polls by the Kaiser Family Foundation since 2010 show that both approval and disapproval have fluctuated around 42-43%. There's never been a clear, strong majority. Either way. But what about public knowledge about the Affordable Care Act? Here we come back to my point about ignorance and confusion that I made at the outset of my remarks. These are the facts. The uninsured rate, proportion of Americans who are uninsured, has plummeted by about 1/3. There are 15 million Americans more now who have health care insurance than did at the beginning of this period. And the Congressional Budget Office said last month that the law will cost less than previously thought. And that is because health care premiums are rising much more slowly than projected, requiring less money in government subsidies. And yet that good news for the law doesn't really seem to be penetrating. The Kaiser poll showed that just 8% of people polled knew the law was costing less than originally estimated, compared with 50% who think it's costing more. Even people who favor the legislation have it backwards, with 14% rightly saying it's costing less and 35% saying it's costing more. So the American public may be confused, but we hope And we trust that after hearing our panelists, you will not be. So let me turn now to the next slide. And I'd like to introduce all three of our panelists now. And this will be the order in which they speak. And you can see their names and you can see the titles of their talks. Kim Wynn is the program manager for the In-Person Assist Navigator program, a New York State Department of Health funded initiative which provides in-person application assistance for individuals and families applying and renewing for health insurance through the New York State of Health Marketplace. That's the name of New York's State Insurance Exchange. She collaborates with a broad array of community partners, and I would say that, I would point out in particular that she is the co-chair of the Finger Lakes Health Systems Agency Partnership on the Uninsured Committee. And lo and behold, her co-chair is also a member of the panel, Christine Wagner. Kim graduated from Dillard University with a bachelor's degree in business administration. She knows all about insurance. Christine, not put any pressure on you. Christine Wagner is the executive director of St. Joseph's Neighborhood Center in Rochester, New York. The center has provided primary care and mental health services to the uninsured in the Rochester area for over 20 years. Christine attended MCC in SUNY Brockport, and she has a PhD from the Maxwell School at Syracuse University. She is a member of the Sisters of St. Joseph, and she serves on the boards of the Greater Rochester Regional Health Information Organization, known as the RIO, and Excellus Blue Cross Blue Shield. And last but not least is our legal expert, Brian Hetherington, Chief Counsel of the Empire Justice Center. He is responsible for managing the legal work of the center based in Rochester. Most of his career has involved complex litigation and other non-litigation advocacy with regard to social services programs, education, housing, and civil rights. Brian came to Rochester in 1980, and he came to serve as litigation director of the Monroe County Legal Assistance Center. He, like the other panels, has a distinguished public service record. He's past president of the Monroe County Bar Association. He's a member of the executive committee of the New York State Bar Association and co-chair of the association's committee on legal aid. He is the board chair of the RIO. We have a lot of intersections here, which I didn't learn until I saw their biographies. And he's past board chair of the Greater Rochester Health Foundation. Brian is a graduate of LaSalle College and the Cornell Law School. So now, let us welcome Kim Wynn as our first speaker.
Thank you and good evening.
We can't hear you.
Okay, I'm here to give you some updates regarding the New York State of Health Marketplace from when the marketplace initially started, which was October 1st of 2013. So I just wanted to provide some information on the 2014 open enrollment as well as the 2015 open enrollment.
Still can't hear you.
Oh, you still can't hear me?
No.
2014, who enrolled into coverage? Next screen, please. For the 2014 enrollment, approximately 1 million individuals enrolled. Out of that 1 million, 55% enrolled in Medicaid, 38% enrolled in a qualified health plan, and 7% enrolled in Child Health Plus. Half were female and half were male. At the time when the individuals applied, 63% were uninsured when they qualified for the qualified health plan. 93% were uninsured but qualified for Medicaid. And then 87% were uninsured and qualified for Child Health Plus. This is for the entire state of New York. Next screen, please. So where are the New York State enrollees and where are they from? The highest percentage came from New York City, which was 52%. 6% came from Western, 12% Central New York, 14% Long Island, and 16% from Central New York. 49% met with a in-person navigator to enroll in health insurance. 41% decided to apply on their own on the website. 11% called the customer service and applied over the phone. Next screen, please. The age of enrollees, it varies. As you can see, the highest percentage of individuals that enrolled in a qualified health plan were from the ages 18 years to 34 years of age. 55% that qualify for the qualified health plan enrolled in a silver plan. 19% enrolled in a bronze, 13% platinum, and 10% in gold. Approximately 74% individuals did qualify for financial assistance. 26% did not qualify and paid the full cost. Next screen. As you can see, for Monroe County, approximately 13,169 individuals enrolled in Medicaid. 2,166 enrolled in Child Health Plus. 11,128 enrolled in a qualified health plan. So the total for Monroe County of individuals that enrolled was 26,463 individuals. Prior to the open enrollment of October 1st, about 57,000 was estimated uninsured in our county. So you can see it's just a little bit less than half, so we still have much work to do. Next screen, please. For 2015, which started November 15th through February 15th of 2015, the state main goal was to retain those individuals that enrolled in 2014, as well as trying to get new enrollees. And this was the first year that individuals actually renewed their health coverage that enrolled during the first open enrollment period. Next screen. So the total cumulative enrollment for our state is a little bit over, it's more than 2.1 million, which is great. New York State has exceeded their target. They initially stated that they wanted to enroll 2 million by the end of the year 2016. So you can see we're well above our target. The total Medicaid enrollment for our state, 1,545,000. Total private coverages, 564,000. And out of that 564,000, 407,000 enrolled in a qualified health plan, and approximately 157,000 in Child Health Plus. Now the total new enrollment for 2015 was 552,000. The total new Medicaid enrollment for 2015 was approximately 373,000. And the total new private coverage for 2015 was estimated at 179,000. And out of that 179,000, 137,000 enrolled in a qualified health plan, and approximately 42,000 in Child Health Plus. As I had mentioned, that this was the first year for renewal, so approximately 87% of individuals did renew their qualified health plan for 2015. So as you can see, New York has done a fantastic job as far as enrolling individuals in health insurance.
Really quick question about the numbers. Is it parsed out how many of these new enrollments are from individuals and families who are prior uninsured, and how many chose to change their insurance because they've been underinsured, for example, or in a job loss situation?
Well, we haven't received the updated information for 2015, so I'm sure that information will be available very soon from the state.
Or from 2014, for example, all of those new enrollees, did you receive information about who had been prior uninsured? Because certainly those, not all 26,000 were uninsured. They, my family included, might have had other insurance and then enrolled through the New York State Health website.
Yes, we don't have that information available for each county, we just have it overall for the state. So the state hasn't provided that information, but they are working on it, and I'm sure once they get all the data for 2015, they'll be able to compare 2014 to see if those individuals, because this is based for the entire state, and it's not broken down by county. Important dates for individual and families. As you know, the special enrollment, open enrollment was from November 15, 2014 to February 15, 2015. And now there is special enrollment period from March 1st through October 31st. The next open enrollment for 2016 will start November 1st to January 31st of 2016. So you can see that the time frame has decreased. Next, please. What consumers need to know now about the special enrollment period? Even though open enrollment has ended, individuals that have a qualifying life event can come into the marketplace. For those individuals that do come into the marketplace, if they come in by the 15th, then their enrollment can start the following month. Next one, please. There is a one-time special enrollment for individuals who learned they had to pay a federal tax penalty for 2014. That special open enrollment period is until April 30th, 2015. So individuals have about 3 days to come in and apply for health insurance if they had to pay a tax penalty. Otherwise, they would need to have a life-changing event to come to the marketplace. Next screen. Now, there is year-round open enrollment available for individuals that qualify for a public health insurance program, which are Medicaid and Child Plus. And then small businesses with 50 or fewer employees also can come in anytime throughout the year. All of the plans within the marketplace, they all provide essential health benefits. And this screen lists what those health essential benefits are. Preventive, wellness, chronic disease, inpatient, outpatient, maternity, newborn care, emergency services, lab imaging, prescription drug, rehabilitative, mental health, pediatric, dental, and vision. These are the benefits that are provided